This presentation is going to review the alterations in the cardiac system. The topics that we're going to cover regarding the veins are varicose veins, chronic venous insufficiency, venous stasis ulcers, thrombus, and superior vena cava syndrome. In terms of the arteries, we're going to review hypertension, orthostatic hypotension, aneurysms, arterial thrombus, atherosclerosis, peripheral vascular disease, and coronary arterial disease. When we refer to a varicose vein, we are talking about a condition where the venous blood is pulled in a dependent manner, and this produces distortion of the vein. It can also cause leakage, increase intravascular hydrostatic pressure, and inflammation to the area. Usually it's going to be seen on the lower extremities. Varicose veins are a result of incompetent valves. It may be that there's venous obstruction or the muscle pump itself is dysfunctional. Many times it is a combination of all these conditions. Increase in venous hydrostatic pressure is associated with an increase in the transforming growth beta. We also refer to this as TGF beta, and the basic fibroblast growth factor, which is BFGF, within the vessel wall. Whenever there's an increase in these two factors, the vessel wall will result in permanent remodeling of the overall vessel. Also, there's risk factors for developing varicose veins, which include women being at higher risk, pregnancy, increased weight, increased age, if there's been a leg trauma, or if you're sitting and standing for long periods of time. Other things that can affect your risk for varicose veins is overall family history. The symptoms that your patients will complain about are distended veins. Sometimes it does cause a bit of itchiness and burning, and they will experience throbbing around the lower leg veins. Some patients will also experience muscle cramping or pain in those lower extremities. Usually it's going to be in the saphenous vein, and you can see these schematics where that long saphenous vein starts at the upper extremity, moving all the way down to the lower extremity. Chronic venous insufficiency is inadequate venous return over a long period of time, in which then it would cause some type of pathologic ischemic changes in the vasculature, can change the skin and the supporting tissues. When this occurs, blood accumulates, or it can actually become stagnant in the lower extremities, and this leads to increased pressure of the vein. This increased pressure therefore causes fluid to leak from the blood vessel into the surrounding tissues. So you have incompetent valves, blood pooling. It can also cause these red blood cells to break down and release iron, and this is what gives it that reddish brown or rust colored discoloration that you will see in patients with venous stasis ulcers. This color is referred to as the hemosiderin staining. Hemosiderin is the iron pigment that is derived from the breakdown of hemoglobin, and over time this pigment is going to accumulate, turning the skin a rusty color, and the underlying tissues are going to be affected as well, and you're going to see this overall discolored appearance. So again, these incompetent valves lead to blood pooling and leaking. You have venous hypertension because this added flow, inadequate arterial perfusion. Well, now you have a decreased oxygenation or perfusion to the skin, the vasculature, and the tissues, where you will have an unmet metabolic situation. This is going to lead to a venous stasis ulcer over time. The most common cause of a venous stasis ulcer is going to be a DVT. So what pressure is actually moving the fluid out of the vessel? This pressure is called hydrostatic pressure. Patients are more likely to have a venous thrombus than an arterial thrombus. Venous thrombus is a situation where there's going to be lower blood flow and lower blood pressure within the venous system, or it can be because there's an obstruction in the venous flow, which leads to increasing venous pressure. Over time, a thrombus will be formed, which is a blood clot that's attached to the vessel wall because there's venous stasis. Once that thrombus detaches and circulates, it becomes a thromboembolus, and sometimes we shorten it and just call it an embolus. Deep vein thrombosis occurs in our patients who have overall venous stasis, and this is going to be at a higher risk for patients that are immobile, they're older, and particularly if they have left heart failure. Patients with spinal cord injury, any damage to the venous walls like trauma or intravenous medications, they're going to be at higher risk for DVT. Along with patients that are in a hypercoagulable state like pregnancy, those that are taking oral contraceptives, malignancy, and genetic coagulopathies. It is often asymptomatic, but can lead to fatal pulmonary emboli as the DVT itself, this embolus, starts to move and eventually reaches your pulmonary system. So prevention and careful assessment is really crucial at this level. It's important for us to understand why these valves are so important, and these small valves help to keep the blood moving toward the heart. And so whenever there's injury, immobility, and factors that lead to the formation of a blood clot, it can eventually, again, move along through, it can break away, become an embolus, and then it enters the circulation where it can be lodged into our lungs and cause a pulmonary embolism. So it's important to understand the triad of Virchow. Sometimes it's called Virchow's triad. And these are the reasons you would be at risk. Again, venous stasis, venous endothelial damage, and states of hypercoagulability. Superior vena cava syndrome is often a syndrome that's difficult for students to understand, and it is not a disease process itself, but a result from compression. And sometimes, oftentimes, it's actually compression of tumors. Now, remembering that the superior vena cava is a major drainage vessel for our venous blood flow of the upper extremities, our head, our neck, and the thoracic area. Whenever there's progressive occlusion, we will start to see venous distension in the upper extremities in the head. Thin-walled, low-pressure vessels in these thoracic compartments can be easily compressed. And what you'll see is edema, venous distension. You'll see fullness in the head, the face. They'll feel tight in the extremities. And oftentimes, you will have patients complain of visual disturbances, headache, and it can often lead to impaired consciousness. This is a clinical manifestation of a progressive compression of the superior vena cava that leads to this type of distension and symptoms. The leading cause of superior vena cava syndrome are non-small cell lung cancer, small cell lung cancer, and lymphoma. There are also some non-malignant causes that you should be aware of as well, like thrombosis, infection, like TB, mediastinal fibrosis, cystic fibrosis, Sometimes a retrosternal goiter can cause that compression to occur as well. Additionally, pacemaker wires, central venous catheters, and pulmonary artery catheters can often lead to superior vena cava syndrome. The most common clinical manifestations like you see are here, but there are some things that will often be reported that you might not directly connect, like dyspnea, dysphagia, hoarseness, stridor, cough, and even chest pain. In addition to these headaches and visual disturbances, your patients may even describe vertigo, memory loss, and you might see that their skin changes. You might see skin becoming very tight or taut, starting to look more purple, and their cap refill can actually be prolonged as well. If you see respiratory distress, this might be a symptom of edema of the bronchial structures, and where you have maybe a respiratory or bronchogenic carcinoma that is putting pressure on the bronchial structures. The way this is diagnosed most often is by chest x-ray. You can also get an ultrasound or a CT, sometimes even an MRI. If the laryngeal area is constricted or there's cerebral edema present, there has to be emergency intervention right away. And we're trying to find that underlying cause of compression on the superior vena cava. What is a condition in which blood has pooled, producing distended and palpable vessels? This is referring again to a varicose vein, which term describes the occlusion of blood vessels from a bolus of circulating matter in the bloodstream. The answer here would be an embolus. It's detached from the wall of a vessel and circulates within the vascular system until it reaches a small vessel, which it can then occlude. Now we're going to move into diseases of the arteries. Just as a review, before we get into more pathophysiological disease processes, we want to talk about the regulation of blood pressure. The pressure itself, what causes hypertension, is an increase in cardiac output and peripheral resistance, or increased peripheral resistance. Now, what can cause your blood pressure or hypertension? Well, if we have an increase in the preload and the volume increases, it can also cause venous constriction. Contractility, which is organized by the sympathetic nervous system, can increase your cardiac output as part of a feedback loop. The peripheral resistance has to do with your hematocrit and your blood viscosity. Your sympathetic nervous system is controlling the vessel diameter in the arteriolar level. It also is going to decide or to regulate constriction versus dilation. These are connected to local regulators like oxygen, potassium, CO2, and hydrogen ion regulation. At the humeral level, we have vasodilators like natriuretic peptides, nitric oxide, adrenomedullin, endothelins, prostacyclins, as opposed to the vasoconstrictors like epinephrine, norepinephrine, angiotensin II, and vasopressin. It's going to be important for you to differentiate the differences between the vasodilators and the vasoconstrictors. There are a combination of both genetic and environmental factors that are responsible for the development of primary hypertension. Genetic predisposition to hypertension is polygenic. It includes polymorphism associated with renal sodium excretion, insulin, our sensitivity to insulin, and the activity that occurs at the sympathetic nervous system level, like we've seen here. It's also important that we understand RAS, the renin-angiotensin-aldosterone system, which we will be going into in a little bit more depth, as well as how our sodium and calcium are transported in our body. There are also epigenetic factors like environment, diet, exercise, smoking, and the way our genes are expressed in these conditions. The more common risk factors for primary hypertension have to do with our age as it increases, our ethnicity, family history of hypertension, genetic factors like we've heard, patients that are at lower education and lower socioeconomic status are at risk, tobacco users, those that have a lot of psychosocial stressors, sleep apnea, dietary factors like high fat, sodium, low potassium, and excessive alcohol drinking. Our patients with diabetes and others that have glucose intolerance and obesity, these are also significant risk factors to remember. In fact, hypertension, dyslipidemia, and glucose intolerance are found together in what we call metabolic syndrome. The definition of hypertension specifically is a consistent elevation of systemic arterial blood pressure. And we define this by these levels here that the American Heart Association and the American Stroke Association recognize as well. And you see a normal blood pressure, systolic is under 120 and diastolic is under 80. We would consider someone to have elevated blood pressure if their systolic was in the range of 120 to 129 and diastolic still less than 80. However, they start to move into stage 1 hypertension if they either have systolic pressure that's sustained at 130 to 139 or a diastolic that is sustained at 80 to 89. And then you can see as we progress more and more, stage 2, 140 or higher systolic or 90 or higher diastolic. A patient is literally in hypertensive crisis if they have a blood pressure systolic of over 180 and a diastolic of 120 or more, or it can be one or the other of these two. There's this term called isolated systolic hypertension, or ISH. And this is when you have an elevated systolic blood pressure that's accompanied by an absolutely normal diastolic blood pressure of less than 90. ISH becomes more prevalent in age groups, all of them, and it's strongly associated with someone that's had a cerebrovascular event or cardiovascular event or having one in the moment. Isolated systolic hypertension is, again, any systolic increase in pressure that's accompanied by normal diastolic pressure of less than 90. So let's talk specifically about the pathophysiology now. We know that blood pressure is regulated by cardiac output and peripheral resistance. Well, hypertension is caused by an increase in cardiac output, total peripheral resistance, or both. And an increase of cardiac output is due to any condition that will increase your heart rate, the stroke volume. An increase in peripheral resistance is anything that increases blood viscosity or reduces the diameter of a blood vessel. This is termed vasoconstriction. There are some complicated interactions as well of genetics and environment that are mediated by our neurohumoral effects. And first, we're going to start talking about the SNS, our sympathetic nervous system. Primary hypertension is a result of a complicated interaction between these two things, which will increase vascular tone. increased vascular tone is equivalent to increased peripheral resistance and blood volume. When we have sustained increases in blood pressure, it's due to vascular tone and blood volume. There are multiple mechanisms that mediate these things. You see here the SNS, but we also have the RAS, which is the renin, angiotensin, aldosterone system, and natriuretic peptides. Inflammation, endothelial damage, obesity, related type hormones, and insulin resistance can contribute as well to both increased peripheral resistance and our increased blood volume. The blood volume or vascular volume increases in relationship to a decrease in the renal secretion of salt, and this is referred to a shift in the pressure natriuresis relationship. What this means is that for a given blood pressure, individuals with hypertension, they tend to secrete less salt in their urine than someone that does not have an increase in hypertension or hypertension. Okay? Natriuretic peptides, therefore, are hormones that modulate this renal sodium excretion. We're going to now move back up to the RAS. Going back to your structure and function slides, you may have seen RAS, hopefully, and you might have remembered this from your physiology course. But we're just going to talk about it in a very simplified form. First, renin. Renin will be released when blood pressure drops or there's a decrease in blood flow in the kidneys. There's cells in the kidneys that are specialized to release renin into the bloodstream as a reaction to low blood pressure or low flow. Well, then angiotensinogen will convert. Okay, so renin will then act on angiotensinogen, which is a protein. It's produced by the liver, but we can find it in the blood. When renin activates this, it cleaves to angiotensinogen, and we're going to form angiotensin 1. Now, as angiotensin 1 circulates through the bloodstream, it starts to reach our lungs. It's going to encounter angiotensin converting enzyme at the lungs. Angiotensin converting enzyme converts angiotensin 1 into angiotensin 2. Once we get angiotensin 2, we now have a very potent vasoconstrictor. When we have a vasoconstrictor, it's going to cause the blood vessel diameter to narrow down, and this narrowing will increase the blood pressure to help restore normal blood flow. It also is going to stimulate the release of aldosterone from the adrenal glands. Once aldosterone is released, we're also going to see mechanisms that will increase blood volume. Aldosterone is a hormone that acts on the kidney, which will promote the reabsorption of sodium water, increasing the excretion of potassium. By doing this, aldosterone is able to help maintain fluid balance, increase blood volume, and it will further contribute to this increased blood pressure. If you notice, this was all a feedback loop, because as blood pressure increases, it's going to inhibit renin from being released from the kidneys, which leads to a decrease in the production of angiotensin 2 and aldosterone because our blood pressure is already high. The negative feedback loop will help to maintain blood pressure within this normal range because it recognizes that we're already at a state of hypertension. Again, renin is only going to be released when it recognizes that there's a drop in blood pressure or a decrease in blood flow. Let's look at primary hypertension one more time. Okay. It can be essential or idiopathic, which means that it is because of these risk factors that we've discussed previously, or it could be a situation where we just don't really understand the etiology of the hypertension. 92 to 95% of individuals with hypertension have some type of genetic or environmental factor. These factors that increase the risk for hypertension are sodium, natriuretic peptide abnormalities, inflammation in the body, obesity, and insulin resistance, where we talked about the metabolic syndrome. For secondary hypertension, it's a little different. It's caused by an underlying disease that raises your peripheral vascular resistance or your cardiac output. Think of having renal vascular disease, or if there is some type of tumor in the adrenocortical gland, or adrenomedullary tumors. Some drugs also can increase our blood pressure, like oral contraceptives, corticosteroids, even antihistamines as well. With secondary hypertension, if you can recognize the cause and identify this and remove it before there's any structural damage that occurs permanently, then you can solve the secondary hypertension. Now we'll look at this more on a graph form because sometimes it's just easier to understand this way. Look at all the many different things on this side of your screen that relate to a decreased renal salt excretion. Or if you were asked, what causes or contributes to the shift in pressure with the natriuresis relationship, you can see here that genetics, an increase in your SNS, increase in the RAS, especially at the aldosterone level. If there's endothelial dysfunction or dysfunction of the natriuretic hormones itself, you'll see this shift in the pressure natriuresis relationship. Increased dietary sodium, insulin resistance, obesity, and renal glomerular and tubular inflammation can lead to a shift in pressure natriuresis relationship. Well, now let's look at how genetics and environment come together and how they are responsible for the development of primary hypertension. You see obesity, we see insulin resistance, adipokines, in relationship to dysfunction in your sympathetic nervous system, the RAS, natriuretic hormones, and inflammation. If there is obesity and insulin resistance in combination to some type of dysfunction in your SNS or your RAS, natriuretic hormones, it can lead to vasoconstriction, which will then increase your peripheral vascular resistance, causing sustained hypertension. Well, dysfunction of your SNS, RAS, and natriuretic hormones with inflammation will also increase renal salt and water retention that increases overall blood volume, leading to sustained hypertension. And with this, vascular remodeling will occur with sustained hypertension, and you see the damage that it can occur with your eyes, your kidneys, your heart, and even neurological diseases. Please spend time looking at the shift in pressure natriuresis relationship. If you really understand this concept, you'll be able to answer quite a bit of questions regarding primary hypertension. And you can see that there are numerous factors that are implicated in the pathogenesis of the sodium retention in patients with hypertension due to the shift in pressure natriuresis relationship. The natriuretic hormone modulates renal sodium excretion, and it requires adequate potassium, calcium, magnesium to function properly. So this is why it's not only important to watch your sodium, but make sure you are taking in enough potassium, calcium, and magnesium. This natriuretic hormone or hormone group includes atrial natriuretic peptide. We also call this ANP. We also have a B-type natriuretic peptide. We call this BNP. C-type natriuretic peptide, CNP, and urodilaptin. These hormones will help to induce diuresis, which then can release some of the blood pressure. It also enhances renal blood flow, glomerular filtration rate, and overall systemic vasodilation. These natriuretic hormones also are responsible for suppressing aldosterone and inhibiting your sympathetic nervous system. So whenever there's dysfunction in these hormones or alterations in the RAS or the SNS, you will get an increase in the vascular tone and the shift in the pressure natriuresis relationship. So what happens to patients with hypertension to their ANP and BNP levels? You're going to see an increase, and this is linked to the increased risk for ventricular hypertrophy, atherosclerosis, and heart failure. The salt retention will lead to water retention, increased blood volume, ultimately contributes to the increase in blood pressure. If we see a patient has complicated hypertension, this is because they've had chronic hypertensive damage to the blood vessel and tissues that lead to the target organs like our heart, kidney, brain, and the eyes. And they're going to start to see damage to these sites. This is when vascular remodeling has started to undergo. With vascular remodeling, we have smooth muscle cells in the walls and the arteries and the arterioles that will start to undergo hypertrophy and hyperplasia at the tunica intima and the tunica media. You're going to see fibrosis here. Once there's enough fibrosis, we're going to see a reduced blood flow, dysfunction of the organs, dysfunction of perfusion, and it's all going to affect these vessels. Endothelial dysfunction, angiotensin II, catecholamines, insulin resistance, and inflammation are what contributes to this process. Look at this diagram that explains RAS, which we talked about earlier. I want you now to take a minute, because you at this point should understand renin, angiotensin 1 converting to angiotensin 2, and aldosterone. How is this contributing to hypertension? So try to talk aloud, talk this out, go through this process, and understand what is responsible for the hypertrophy of myocardium. What is responsible for myocardial ischemia? How is RAS activated? And perhaps, how do we stop it from progressing? Remember that in a healthy individual, RAS provides an important homeostatic mechanism for maintaining adequate blood pressure and therefore also adequate tissue perfusion. In patients that have hypertension, there's an overactivity of RAS that contributes to salt and water retention, increased vascular resistance. What are the complications of a patient with uncontrolled hypertension? We can see cardiovascular complications that include angina pectoris, left ventricular hypertrophy, which will eventually lead to cardiac heart failure, congestive heart failure. This is also called left-sided heart failure. We'll see an increase in coronary heart disease, myocardial infarction, and even sudden death. Myocardial hypertrophy is mediated by several neurohormonal substances that include the SNS and angiotensin II. What is hypertrophy? This is when we have changes in the myocyte proteins, apoptosis of the myocytes, and deposition of collagen within the heart muscle. This will make the heart muscle become thick, scarred, and it's less able to relax during diastole, which literally means the period of relaxation. This will lead to heart failure with preserved ejection fraction. Additionally, the increase in size of the heart muscle makes it that there's going to be an increase in the demand for oxygen over time because now the heart is larger. Well, this will also impair the contractility of the heart, which decreases cardiac output. And now your patient is in increased risk for systolic heart failure. While this is happening, there's also vascular complications like dissection, rupture of aneurysms, intermittent claudication, and gangrene that can result from vessel occlusion. Well, we're not just affecting the heart, we also have to consider what's going on with the kidneys. There's renal complications are the parenchymal damage, nephrosclerosis, renal arterial sclerosis, and even eventually renal insufficiency that can lead to renal failure. We will also see microalbuminuria, which means that microalbumin, or albumin, which is a protein, we'll see small amounts of protein in the urine, so microalbuminuria. This is an early sign that there's going to be renal dysfunction, and we also note that at this time we are at significant increase for cardiovascular events. We'll see changes to the vascular beds of the eyes, and it can be estimated by looking at the arterioles of the retina. If you see retinal vascular sclerosis, exudation, and hemorrhage, this can mean that a cerebrovascular accident can be impending. Cerebrovascular accident or stroke complications are very similar to those of other types of arterial disease processes like transient ischemia, stroke, cerebral thrombosis, aneurysm, and hemorrhage. Chronic hypertension has been linked to all of these things. So please recognize the pathologic effects of sustained, complicated primary hypertension over time to the heart, especially the myocardium and coronary arteries, your kidneys, your brain, your eyes, aorta, and the arteries of your lower extremities. And you can see this nicely on this chart. When a patient is said to be in a malignant hypertensive crisis, this is where there's a rapid progression of hypertension, where now diastolic pressure is going to be greater than 140 millimeters per mercury. That's diastolic pressure over 140. Though it's uncommon, it can be a complication of primary hypertension. There's other causes, though, that can cause malignant hypertension, like pregnancy and reaction to certain medications, adrenal tumors, alcohol withdrawal, and even cocaine and amphetamine use. When this happens, it's a situation where there's high arterial pressure that renders the cerebral arterioles, making them incapable of regulating the blood flow to the cerebral capillary beds. This situation, there's going to be high hydrostatic pressure in the capillaries that cause vascular fluid to exude out into the interstitial space because your capillaries can't take any more pressure. It has to go somewhere. And when it moves into the interstitial space, this is where the problem lies. The blood pressure is not reduced, cerebral edema and cerebral dysfunction is going to occur. Things like encephalopathy. Eventually, if it's still not corrected, it can cause a patient to die. Besides encephalopathy, hypertensive crisis can cause papilledema, so edema of the eyes, cardiac failure, uremia, retinopathy, and cerebrovascular accidents. These are all medical emergencies, and treatment has to be initiated very quickly to help any of these serious complications. Otherwise, it's going to lead to life-threatening organ damage and then eventually death. The early stages of hypertension, again, don't have any manifestations other than maybe a little bit of elevated blood pressure. This is why it's called the silent disease or silent killer, because over time, the hypertension continues to creep up. These patients may never have any signs and symptoms or complications until it becomes too late and they're very ill and they have some type of hypertensive crisis. Most clinical manifestations of hypertension are going to be, if you can see them, complications that affect the target organs, which we keep discussing. Evidence of heart disease, renal insufficiency, central nervous system dysfunction, impaired vision, impaired mobility, vascular exclusion, edema. These can all be caused by sustained, untreated hypertension. A patient experiences a rapidly progressive hypertension with a diastolic pressure of 146 millimeters of mercury. What is this called? If you said malignant hypertension or hypertensive crisis, you're correct. What characteristics are associated with hypertension? Select all that apply. It's true that if you have a family history of hypertension, you're at higher risk. A. If you have high dietary sodium, you're at higher risk. C. Glucose intolerance and obesity, which is part of the metabolic syndrome, are another or two other risk factors for hypertension. So A, C, D, and E. What complication occurs secondary to hypertension? Now, secondary to hypertension, you are going to see congestive heart failure because you're going to have ventricular hypertrophy, angina pectoris, congestive heart failure, coronary artery disease, myocardial infarction, and sudden death are your risk factors for secondary hypertension complications. Now we're shifting from hypertension to hypotension or low blood pressure. Orthostatic hypotension, also called postural hypotension, refers to a decrease in your systolic pressure of at least 20 millimeters of mercury or a decrease in your diastolic pressure of at least 10 millimeters of mercury. And this is all within 3 minutes of either moving to a standing position or laying to a sitting position. And primary orthostatic hypertension is often also called neurogenic hypertension. And this is because it's usually a result of some type of neurologic disorder, like autonomic functions that are being affected. There will be compensatory changes during the time where you're standing, which will normally increase your sympathetic activity, all mediated by baroreceptors or stretch receptors in your carotid sinus, located at the carotid sinus, but also can be found in the aortic arch. These reflexes respond to the shifts in volume caused by these postural changes. And so when they work really well, it's great because it's helping to regulate your movement and what happens to your blood pressure during this movement. Postural changes will lead to prompt increases in your heart rate, constriction of the systemic arterioles, which will then maintain the stable blood pressure. The compensatory mechanisms aren't effective in maintaining your blood pressure when you have orthostatic hypotension. Okay, so this is the main thing. The compensatory mechanisms aren't effective in maintaining the stable blood pressure when you have orthostatic hypotension. Most of the time, patients that have primary orthostatic hypotension, it's a chronic illness. Usually older adults are going to be more susceptible to this type of orthostatic hypotension because you have slowing of postural reflexes as you get old. Also, they're more likely to have these neurologic diseases like Parkinson's and multiple system atrophy, or they've inherited some type of neurologic disorder. When we talk about multiple system atrophy, we're talking about a severe form of chronic autonomic failure where multiple central nervous system degeneration changes will occur, and Parkinson's disease is part of this process. Secondary orthostatic hypotension is often acute and associated with some changes in your body chemistry, some type of drug reaction like hypertensives or antidepressants. If you've had some prolonged immobility that's caused by an underlying illness, if you have been going through the process of physical exhaustion, starvation, or anything that would produce volume depletion like potassium or sodium depletion or massive diuresis, maybe someone that's on Lasix and they are diuresing quite a bit, you could have a situation of secondary postural hypotension. Or any condition really that results in venous pooling, pregnancy, varicosities like varicose veins, anything that's causing blood to pool in the venous system. The other more chronic forms of secondary orthostatic hypotension, this is seen when you have a patient with adrenal insufficiency, diabetes, other cardiovascular diseases as well. What are you going to see in your patient? You're going to see dizziness, blurred vision, loss of vision even, syncope, which is fainting. And to assess a hypotensive episode, you're checking for the frequency, severity, and correlation of their symptoms overall. And most of the time when someone has such unstable blood pressure, you are monitoring their blood pressure at least for 24 hours. You can also get electrolyte measurements and get an EKG or an ECG as well. Some patients, though, if you think it has to do with the autonomic system, they're going to have autonomic testing. You're going to measure their catecholamines and their heart rate variability. When you are dealing with orthostatic hypertension, the treatment of secondary orthostatic hypertension really is going to be focusing on correcting the underlying disorder, what caused it in the first place. Now, there isn't anything to cure primary orthostatic hypertension, but you can manage it by helping to raise the head of the bed. You can have them wear thigh-high compression stockings. Also, giving erythropoietin can help, or other volume expanders, mineralocorticoids, vasoconstrictors, and liberalizing the amount of salt that your patient is eating. We're going to move on now to the topic of aneurysms, which are commonly going to occur in either the thoracic area or the abdominal aorta. And the aorta is a particularly susceptible vessel for aneurysm because of the constant stress that is put on this vessel wall. And the absence of having penetrating vasa vasorum in the medial layer makes it also susceptible for aneurysm. Atherosclerosis and hypertension are found in more than half of our patients with aneurysm. So it's important to make this connection to understand the risk factors. And with chronic hypertension, it will result in mechanical and shear forces contributing to the remodeling that is occurring at the vessel wall, and therefore it will weaken the vessel wall. So again, atherosclerosis is a common cause. That plaque formation will erode the vessel wall eventually. And when you study abdominal aortic aneurysms, the main pathologic feature really includes the extracellular matrix remodeling and the loss of the vascular smooth muscle cells. In addition, there's going to be an accumulation of inflammatory cells. And these inflammatory cells, or the inflammatory process overall, is critical to the influence of aortic wall remodeling. And possibly it's the result of monocytes and macrophages. Infections such as syphilis and other collagen disorders like Marfan syndrome, traumatic injury to the chest or the abdomen, these can be additional causes for aortic aneurysm. There are some genetic susceptibilities as well, like polymorphism, that have to do with the production of growth factors, myosin, and proteases that would weaken the cell wall. Inflammation, especially with the production of toxic oxygen radicals, changes in cytokines, will activate the matrix degrading proteins in the smooth muscle cells that will set off apoptosis. And what we have in result is the loss of medial elastic lamellae and thinning of the tunica media. So a true aneurysm is where this damage and thinning is occurring in all three layers of the aorta. A false aneurysm is when it's only affecting the extravascular hematoma, or extravascular hematoma is occurring through that layer. You can see that it really is an outpouching of the radius of the vessel, which causes an increased tension, and more often than not is an outpouching. You can see with the fusiform or circumferential, which we're calling it a true aneurysm, all three layers are being pushed out to this outpouching. Where do you see it, the false? There's sometimes it's called dissecting or saccular or berry aneurysm. It's only that extravascular layer that is outpouching. Now, we can also blame atherosclerosis for putting a patient at risk for arterial thrombosis. And with arterial thrombosis, it tends to develop wherever there is a situation where intravascularly there's going to be an activation of coagulation or the clotting cascade. And within our arteries, this activation of coagulation cascade most often is going to occur when there is a condition that roughens the tunica intima. And this condition is atherosclerosis. But there's some other important things that could cause the anatomical changes of the artery, like an aneurysm, which we saw in the previous slide. This can also stimulate thrombus formation as well, especially if there's pooling of the arterial blood in that area. Usually you are going to find thrombi forming where there has been some calcification or bacteria vegetation within the vessel. Most commonly, thrombi are going to be associated with conditions of inflammation of the endocardium, like endocarditis, or rheumatic heart disease as well. But when you have widespread arterial thrombus formation, this can occur in situations of shock, specifically when we have septicemia. In septic shock, there will be systemic inflammation, which will activate both our intrinsic and our extrinsic pathways of coagulation, which will result in microvascular thrombus throughout our systemic arterial circulation. And it's going to pose two different threats. First, it can grow large enough that it could occlude the entire artery. You can see this thrombus is almost occluding the entire artery. But second, the thrombus can actually dislodge and become an embolus or thromboembolus. And this thromboembolus will now have the ability to travel through the vascular system until eventually it occludes somewhere in the distal systemic vascular bed. So how do we diagnose arterial thrombi? Well, first, we can use our patient's signs and symptoms to clue us into maybe we need a Doppler ultrasound. Angiography can also help us, where we can light up through um, contrast dye the vascular system to see if there's areas of occlusion. Pharmacologic treatment can also help. We can administer heparin, warfarin, and other thrombin inhibitors or thrombolytics. In these situations, a balloon tip catheter can actually be used to remove or compress the thrombi. And there are some various combinations of drugs and catheter therapies that are used together. And you'll learn more about this in your med-surg course. Now, we talked about endothelial damage, but let's also, and we blame that on atherosclerosis, but let's also talk about AFib. Arterial fibrillation is a dysrhythmia that can also cause thromboemboli, and it's the most common source of arterial thromboemboli. And this is when your heart is firing at an average rate of about 400 to 600 beats per minute. And if your heart is firing that fast, it's not doing an efficient job at moving blood through and causing blood to flow. And so the blood eventually pulls in the atria and it leads to clot formation. Now, once the embolus moves out, and we talked about moving to different vascular beds in the periphery, if it occludes the coronary artery, then we have risk for myocardial infarction. And if it occludes the cerebral artery, this is when we have a situation, a cerebrovascular accident, so either heart attack or a stroke. Now, there are other types of embolisms like venous embolisms, amniotic fluid, fat, and bacterial embolisms as well, that you can read about in more detail in your textbook, but we will review as an overview on the next slide. All right, so these are the 4 types of embolism, and we'll just review thromboembolism again, although you got much more detail in the previous slide. A thromboembolism is a vascular obstruction that's going to result from a thrombus that has dislodged and now is in motion. So pulmonary emboli will originate in the venous circulation, mostly from deep vein thrombosis of the legs, or it can be lodged from the right side of the heart, where an arterial emboli is commonly going to originate from the left side of the heart, and it's a result of a myocardial infarction, some type of valvular disease, left heart failure, endocarditis, or dysrhythmia like AFib. So also important to understand the difference between the right and the left side. Now, an air embolism is when you have air circulating or entering the circulation and then now circulating through an IV line. This is the most common cause of air embolism, and it can be introduced into the bloodstream if there's some type of trauma, or the chest causes air from the lungs to enter now into the vascular space where it doesn't belong. So think about a patient that has had a trauma or a gunshot wound or a puncture wound in the thoracic area. And sometimes this can introduce an air emboli into the circulatory system. Now, room air is about 70% nitrogen, but nitrogen dissolves quickly in blood. But large amounts of air can't be dissolved as rapidly, and therefore we can have this displacement of blood in the arterioles and the capillary beds. In this situation, ischemia and necrosis can occur and block the total blood vessel. Air embolism treatment is just supportive care, making sure your patient is on bed rest, getting the supplemental oxygen that they need, and making sure that whatever is causing that source of room air to enter the vascular system is eliminated. With bacterial embolisms, we will get this when there is one type of bacteria or bacterium that it's been isolated in the bloodstream. And usually within itself, it's not going to cause the embolus, but when we hit aggregates of bacteria together in large enough amounts, it could cause a bacterial embolism. And the most common cause of this bacterial embolisms are going to be conditions like infectious endocarditis. And with this disease process, there's going to be clumps of bacterial vegetations that are forming, and they become dislodged when you have maybe an infected cardiac valve, or there could be injection into the pulmonary or systemic circulations due to our natural pumping of blood throughout our body. There's also a less common cause of bacterial embolism, and this is erosion of an artery or vein by bacteria at the site of infection. And this can occur if a patient has an abscess. And we would treat bacterial embolism with obviously antibiotics because we were trying to eradicate the source of infection, but also bed rest and supplemental oxygen as well. And then lastly, with fat embolism, think about a trauma that can hurt a bone. Okay, so you broke a bone, you injured your bone. This can initiate defective fat metabolism, which will cause fat globules to form within the blood. Now, platelets will begin to adhere to these globules until the platelets are large enough, the area where the platelets are adhering, until it's large enough to lodge into a capillary bed. And this can also be a situation where you would have to provide supportive care, figure out how we can reduce that adherence of platelets, and all in all, these four types of embolisms, it's really going to be important for you to distinguish the difference between the four and what type of conditions would lead to each type of embolism. Let's practice. A patient presents to the emergency department reporting difficulty swallowing and shortness of breath, and the CT scan is most likely going to reveal an aneurysm where. Now think about the anatomy of the signs and symptoms they're reporting. So shortness of breath, difficulty swallowing in the thoracic area. And we know that by the lecture, thoracic aortic aneurysms are very common, and they can cause dysphagia, which is difficulty swallowing, dyspnea, shortness of breath, or breathlessness, and therefore the answer is going to be D. If it was going to be in the cerebral vessels, you would have more complaints about headache or maybe high blood pressure, visual disturbances, loss of consciousness. In the renal arteries, you would have common side effects or signs and symptoms of flank pain or back pain. Inferior vena cava, if this was the case, you would have more reports of chest pain. So therefore, the answer here is thoracic aorta. All right, now it's time to move on to peripheral vascular diseases. And the first one that we're going to talk about is called Buerger's disease, or thromboangiitis obliterans. And thromboangiitis obliterans is an idiopathic autoimmune condition, meaning that we don't often know why it happens in the first place, but it is associated to patients that are smokers. And what we will see is the formation of thrombi filled with inflammation and immune cells that will disrupt the flow of our peripheral vascular system, specifically our arteries. These inflammatory cytokines and toxic oxygen radicals contribute to the vasospasm that is occurring, which you can see will induce the changing of our skin. Usually it happens in the feet, but sometimes we can also see it in our hands. Now, over time, these thrombi become so organized and fibrotic that we can have a situation of permanent occlusion and obliteration of portions of small and medium-sized arteries in the feet. Now, typically, we are going to see that it will affect the digital, tibial, and plantar arteries of the feet and the digital palmar and ulnar arteries of the hand. What you're looking for in terms of the chief symptoms of thromboangiitis obliterans are pain, tenderness to the hands or the feet, and you'll see very sluggish blood flow. You'll also see rubor, which is redness of the skin, and this is because the capillaries will be dilated, but you're also going to see cyanosis too, because the blood that remains in the capillaries has been now diffused into the interstitium. Chronic ischemia is also going to cause the skin to become very thin and shiny, and your nails are going to be thickened and malformed as well. When a patient has advanced Buerger's disease, the ischemia can eventually lead to gangrene, and this would require amputation of the hands and feet. Normally, patients with Buerger's disease will be diagnosed at a younger age. Less than 45 is mostly when our patients are diagnosed with thromboangiitis obliterans, and they will have a smoking history. They'll also have visible signs of peripheral ischemia. And what you would do is rule out any other causes of arterial insufficiency. The most important part of treating this patient is telling them that they're going to need to start, quit smoking or start a smoking cessation program. Vasodilators can also be prescribed because we need to alleviate that vasospasm, and we need dilation to occur. And you want to make sure that your patient receives instruction on how to exercise, because that gravity will improve blood flow to the arms and the feet as well. There are other new therapies that are out there which you will learn again in your med-surg course. One other peripheral vascular disease worth noting is Raynaud's phenomenon, and this is primarily a vasospastic disorder, and again, it's idiopathic. We don't really understand why, but we know that nearly 5% of the patients with Raynaud's phenomenon are going to be female. They will have a family history of Raynaud's. They would be a smoker. They also will have an affinity for migraines or cardiovascular disease as well. And in Raynaud's, the blood vessels are going to be affected because of endothelial dysfunction with an imbalance between the endothelium-derived vasodilators like nitric oxide and vasoconstrictors as well. And platelet activation plays a role here too, as well as the vasospastic attacks that are triggered by exposure to cold or emotional states. Many times I have seen this as or in relationship to very cold temperatures. Now, Raynaud's phenomenon that's secondary to Raynaud's is a systemic disease that has to do with collagen vascular diseases or scleroderma, or even chemotherapy or cocaine. We might also see Raynaud's phenomenon with hypothyroidism, pulmonary hypertension, serum sickness, vasculitis, and malignancy. Raynaud's phenomenon will have vascular inflammation and vasospasm that are reflective of a progression of underlying disease. Okay, so the difference again, Raynaud's disease, usually idiopathic. Raynaud's phenomenon, it's systemic in relationship to other diseases. So as far as clinical manifestations go, you're going to see pallor, numbness, and the fingers of your patient are going to feel very cold. And the attacks tend to be bilaterally, and first clinical manifestations are going to begin at the tips of the fingers and then progress to the proximal phalanges or proximally towards your palm. You'll also see sluggish blood flow resulting in ischemia, and the skin also will look cyanotic. The rubor will follow as the vasospasm ends and then capillaries become engorged with oxygenated blood. Rubor is often going to be accompanied by throbbing in your fingertips, and they might feel tingly and numb, which is the paresthesia. Eventually, that skin color will return back to normal, and they should have a resolve in those tingling symptoms. But frequent prolonged attacks can cause longer term damage to the skin of the fingertips. It can actually make your skin up there very thick and your nails become very brittle. And in severe chronic Raynaud's phenomenon, ischemia can eventually cause ulceration and again gangrene. But this is more likely from Raynaud's phenomenon and not Raynaud's disease, which is idiopathic. Okay, so the treatment of this is to avoid the trigger. So if it's cold or emotional state, avoid those things whenever possible. You can also use arm exercises to help, vasodilators. The treatment of Raynaud's phenomenon, however, is removing the stimulus, but thinking about treating the primary disease that put you in this Raynaud phenomenon process as well. And when Raynaud's phenomenon is associated specifically with malignancy, you may have to consider surgical removal of the tumor to resolve the ischemia and not just chemotherapy. It's important with Raynaud's disease and phenomenon that you avoid nicotine because it has a vasoconstrictive effect. Okay, so this is why our patients that are smokers are more likely to have Raynaud's as well. Let's practice. This is a young woman who presents with pallor, numbness, and sensation of cold temperatures to her digit. What condition is most likely the cause of her symptoms? Now, hopefully you picked Raynaud's phenomenon because we just talked about that, or Raynaud's disease, and it's characterized by the vasospasm attacks in the small arteries of the fingers, and it's triggered more often than not from cold, but also from emotional states. Now, thromboangiitis obliterans has to do with inflammation of the peripheral arteries that usually occurs in young men and heavy smokers, and more often we're going to see this in the feet over the fingers. Peripheral vascular disease is a result of atherosclerosis, and varicose veins are a situation where we have pulled blood due to incompetent leg calf muscles or valves that are pushing the blood flow back towards the heart. Now, so far, we have blamed many cardiovascular conditions to atherosclerosis, so let's find out at a pathologic level what is going on. Now, it's a form of arteriosclerosis in which there's thickening and hardening of the vessel, and it's caused by an accumulation of lipid-laden macrophages within that arterial wall, which will lead to the formation of a plaque, which is a lesion of the vessel wall. Well, what causes the lipid-laden macrophages to arrive in that place in the first place is what we want to know. But first, we have to understand that atherosclerosis itself isn't a single disease, but it's a pathologic process that affects the vascular system in many ways, and there's many different interactions on a pathophysiologic level that is happening to create this plaque or eventual occlusion. It is the leading cause of coronary artery and cerebral vascular disease, which means it's the leading cause of MI and stroke. So first, there has to be an insult or an injury to the endothelial cell wall that lines the artery. And these lesions will progress from the endothelial injury, and eventually there's going to be dysfunction, leading to fatty strap fibrotic plaques to accumulate within that lesion. The causes of endothelial injury, what are they? As we get old, we are at higher risk for endothelial injury. If we're a smoker, we have high blood pressure or hypertension. Diabetes is also a risk factor for atherosclerosis. It's anything that's going to cause inflammation to our vessels and overall wall damage of the arteries. And we're going to learn more about that when we get into coronary artery disease specifically. Okay. Now, moving into part B, the fatty streak. There are several receptors on these macrophages that will cause or enable the detection of oxidized low density lipoproteins, and they will engulf these LDLs. Once the macrophages engulf the LDLs, they become lipid laden macrophages, and we will refer to them now as foam cells. When foam cells accumulate in significant amounts, they all group together, eventually you're going to see a fatty streak. Numerous inflammatory cytokines will then be released in response to the fatty streak. Things like tumor necrosis factor alpha, interferon, C-reactive protein or CRP, and interleukins. But we're also going to have enzymes that will injure the vessel wall as well. We'll have growth factors, platelet-derived growth factors, and these growth factors will stimulate the smooth muscle cell to proliferate into a affected vessel. Now we have this fatty streak that turned into a eventual fibrous plaque. Okay, so the smooth muscle cells produce collagen and they will migrate over the fatty streak. When they come over the fatty streak, now they're forming a fibrous plaque. The plaque itself is consisting of various substances like cholesterol, fatty acids, and calcium. So important to know what a fatty plaque is made of. And eventually they calcify, they protrude within the vessel lumen, and they can obstruct the blood flow to distal tissues, especially during periods of exercise or exertion. And commonly they can cause angina or chest pain or even intermittent claudication. Over time, the plaques will further calcify, leading to the formation of calcium deposits in the arterial walls. And we are most worried about are calcifications within the heart or the coronary arteries because this can lead to MI. Now, with D, these plaques, many plaques, will eventually get to a period where they become unstable. And if they are unstable, they're going to be prone to rupture and movement. Even before they affect the blood flow and are clinically silent, there are issues. But many times we don't know that there's issues because, again, they're clinically silent. We don't have any signs and symptoms. It's not really affecting how the patient feels until they rupture. When the plaque ruptures because of inflammatory activation of proteinases, apoptosis of the cells within the plaque itself, or the lesion starts to bleed. Okay, this is what we call a plaque hemorrhage. When the plaques rupture, this is when we have a complicated plaque lesion, and it will leave the underlying tissue to be exposed. Well, the platelets want to help out when there's exposed tissue. So we have platelet adhesion. And when platelets come, this will initiate a clotting cascade. This clotting cascade will then be accompanied by rapid thrombus formation. And suddenly, we have this big thrombus that can occlude the affected vessel. With occlusion of a vessel, we can have ischemia if it's occluded for under 20 minutes, but over 20 minutes, it is now a vessel infarction. Oftentimes, we'll use aspirin or antithrombolytic medications to prevent the complication of further atherosclerotic diseases. But if you find a plaque and it's at risk for occlusion, it needs to be removed either medically or surgically. Now that we have an overview of plaque formation, let's get back to a level where we are spending more time investigating low density lipoprotein oxidation. And with LDL, or low density lipoprotein, LDLs will penetrate into the subintima of the arterial wall. And this is where it can get trapped because there's proteoglycans there. Inflammation, oxidative stress, activation of macrophages all leads to aggregated LDL to become oxidized. Now, hypertension, increased levels of LDL, oxidative stress, if our renin, angiotensin, aldosterone system gets activated, this is all going to contribute to acceleration of atherogenesis, which is the beginning of atherosclerosis. Inflammation, oxidized LDL, can also cause endothelial cells to express adhesion molecules. These adhesion molecules bind to the monocytes and other inflammatory immune systems, and they will penetrate into the vessel wall, eventually becoming the macrophages. Okay, so this is just a little tidbit of more detail coming from the overview of the last slide. Remembering that this LDL lipoprotein oxidation is what is going to trigger monocytes to come, turn into macrophages, engulf, becoming lipid-laden, causing a formation of foam cells, accumulating to form a fatty streak, and eventually leading to inflammatory cytokines that are further damaging the vessel wall. This will lead to a thrombus and eventually occluding because of the plaque formation. Now we're going to move on to peripheral arterial disease. And many students often will get arterial disease mixed up with venous disorders. I want you to remember that with arterial disease, our artery system is made up of high pressure versus the venous system is made up of low pressure. Peripheral arterial disease, or PAD, refers to atherosclerotic diseases of the arteries that are perfusing our arms and our legs, especially the disease processes that we'll be talking about are occurring in the lower extremities. About 15% of all our patients that are over the age of 60 will have significant morbidity and mortality associated to having a diagnosis of peripheral arterial disease. And it needs to, our patients need to be educated on the connection to atherosclerotic disease and having peripheral arterial disease. And most of these patients need to have education on smoking cessation, and especially those with diabetes. PAD is a significant predictor of systemic atherosclerotic diseases, and the documented amount of patients that have PAD in the US has really nearly doubled the risk of coronary artery disease than those patients that do not have PAD. Okay, so you're more at risk. In terms of lower extremity ischemia that can result from PAD, this is due to obstruction. And the obstruction can either be gradual or it could be acute. In most individuals, it's gradually increasing obstruction that causes the arterial blood flow to the legs to be slowed down or obstructed. And it's due to atherosclerosis in the iliofemoral vessels. When this starts to happen, this process, your patients will complain of increased pain and ambulation, and this is called intermittent claudication. When ischemia is not painful, it can go undetected for years, and sometimes with PAD, they won't have any signs and symptoms. When a thrombus forms over an atherosclerotic lesion, then you're going to have issues with perfusion. And this is when your patients will first start to experience pain, severe pain, loss of pulses, and you're going to see some color changes that are going to affect these extremities. Now, you learned from health assessment that you can do a very comprehensive peripheral vascular assessment, and it does require careful subjective history as well as the physical exam, and you're focusing it on cardiovascular diseases, specifically on atherosclerotic diseases. You're looking for bruits. You might get an ankle brachial index, or maybe get a Doppler measurement of the blood flow in the arms and the legs. We've already discussed the importance of smoking cessation and treating diabetes appropriately, but also have a conversation with your patients about hypertension and dyslipidemia. And some patients may need to be on an antiplatelet therapy as well, especially those that are more prone to thrombus. Now, if there is symptomatic PAD, this is when it's going to be managed a little bit more aggressively, and you may have to add vasodilators in combination with the antiplatelet or antithrombotic that your patient is on. We will have oftentimes patients on statins or cholesterol lowering medications. We'll ask them to exercise more, get more active, and if there is something that acutely happens or you're seeing refractory symptoms, then emergent percutaneous or surgical revascularization may be indicated. And so this is where we're going to need some type of it's kind of a mildly invasive procedure. And usually this will happen in the cath lab. Remember that where there's a decrease in blood flow, there's a decrease in oxygen. That oxygen leads to ischemia. The ischemia will cause pain, and then your patient can be said to have intermittent claudication. Okay. With coronary artery disease, we want to think about the disease processes that now are becoming more dangerous to the patient's overall health. And under the umbrella of coronary artery disease is myocardial ischemia. And myocardial ischemia, as well as MI, under this coronary artery disease is a continuum of pathological changes that impairs the pumping ability of our heart. And when we're not able to pump blood appropriately, then we are putting our heart in a condition depriving the heart muscle of blood-borne oxygens as well as nutrients. So in the beginning, the earliest part of this continuum is coronary artery disease. And this is when our patients have atherosclerosis that occludes their coronary arteries. Remembering from anatomy, the coronary arteries are the ones that are bringing blood to the heart, the actual blood feeding the heart muscle. Now, CAD can diminish that myocardial blood supply to a point where the deprivation of blood and oxygen causes myocardial metabolism deficiencies, leading to ischemia. And this is when locally in that area of the heart tissue, the cells are temporarily without blood supply. Okay. And the muscle cells in the heart can remain alive, but they can't function normally under these conditions. And when there's persistent ischemia, or When an acute occlusion or a complete occlusion of the coronary artery occurs, then now we're under um, a time where this patient's having acute coronary syndromes. Now, when does ischemia move into infarction? And you're going to hear me say this several times during our presentation to help you remember. Now, ischemia can last under 20 minutes before we have permanent damage to the cell. Once it goes over 20 minutes, we're going to have permanent damage. And this is when, now in the continuum, CAD led to myocardial ischemia. This is where ischemia is leading to infarction. And let's just review atherosclerosis again. We know that it is the most common cause of CAD. And as a reminder, this is when we have those lipids turning into plaques. We have calcium deposits, which all will narrow the lumen of the artery, causing a reduction in the blood flow, can often cause obstruction, thrombus, or an embolus as well. Okay, so this is a major cause of myocardial ischemia. Now that we have just a little bit of understanding where coronary artery disease can go, let's just talk about quickly what are those risk factors. Now, obviously, there's some non-modifiable risk factors like our age, our family history, our gender, and being postmenopausal actually puts you at more risk as well. Then we have the things that are modifiable, things that we hope to help our patients to take care of before it gets to a point where it does lead to coronary artery disease. And this is dyslipidemia, which is high cholesterol, hypertension or high blood pressure, cigarette smoking, diabetes, their sedentary lifestyle or obesity, and having an atherogenic diet. The non-traditional risk factors that NCLEX style questions want you to know are that there are some markers of inflammation that we can see to detect a higher risk for CAD. And that would be the high sensitivity CRP, which tells us that there is an inflammatory process in the body. Now, highly sensitive CRP is a protein that is mostly synthesized by your liver, and it can give us an indirect measurement of the plaque or atherosclerosis that's related to inflammation in your body. And it does give us a number to trend about plaque progression. When you have high levels of homocysteine, this is considered a cardiac risk factor, but it's not a measurement, so to speak, of atherosclerotic plaque. But sometimes providers will call for this lab just to see what the overall picture is. And knowing that high hypertension is a risk factor, we can also look at blood pressure. And knowing that high cholesterol is a risk factor, we can also look for LDL. But though it tells us they're at higher risk, it's not the best way to determine what our patient's atherosclerotic plaque inflammation and progression is like. Okay, so it's a highly sensitive CRP. There are other things that tell us there's infection in our body, like checking for H. pylori, which you would see in patients maybe with GERD or peptic ulcer disease, chlamydia, CMV, or any type of periodontal disease as well. Air pollution, because it will set off macrophage activation and therefore also associated to LDL oxidation. Now, troponin is another biomarker, troponin 1, that is sensitive to coronary artery disease. Specifically, it identifies the risk for myocardial infarction. And many times after a patient has had an MI, we can trend the troponin to see and to confirm and then to reevaluate. There's also adipokines that can be released from adipose cells too that help us to understand these risk factors. With dyslipidemia, more in depth now, I do want you to understand that this term is used whenever there's abnormal concentrations of the lipoproteins that are detected in the serum blood. And these abnormalities are as a result of a combination of our own dietary factors, but genetics as well. And you can see the criteria for dyslipidemia in this table on the slide. We can look at total cholesterol, our LDLs, which are our bad cholesterol, triglycerides, and our HDLs, which are considered our good cholesterols. You can use these independently or together to determine the risk. There are some genetic defects that cause abnormalities in the way our body or our lipid metabolizing enzymes act, and abnormal cellular lipid receptors as well. There are secondary causes of dyslipidemia also. Patients with diabetes, hyperthyroidism, pancreatitis, nephrosis, they're all at a secondary risk for dyslipidemia. And those patients that use diuretics, beta blockers, and glucocorticoids also. Okay, so although we can obtain cholesterol from our dietary fat intake, most of our bodies are also, our body cells are also making their own cholesterol. And so we have this natural cholesterol in our body, and then we add to it as well. Cholesterol really isn't affected by aging, or our cells are only producing cholesterol when dietary fat is low. Most of cholesterol is not converted to the LDL form. We tend to blame a lot on LDL, but that's just a piece of the overall puzzle. The link between CAD and abnormal plasma lipoprotein concentration is well documented, however, and this term lipoprotein, it refers to lipids, phospholipids, cholesterol, and triglycerides that bind to carrier proteins. Okay, so lipids, in particular cholesterol, it's required by most of our cells to repair plasma membranes in our body. So we have to understand and give credit to how cholesterol does add to our overall body. But even though it's necessary to for our body to manufacture these substances, like bile acids and steroid hormones that require cholesterol, we also need to be careful that balance of adding the dietary fat being manufactured to more cholesterol. A patient is diagnosed with coronary artery disease. Now, which of the following modifiable risks would you suggest the patient to change? So there is a lot here that could help our overall health, but the only one that is a modifiable risk factor that is associated directly to CAD is cigarette smoking. And the reason is that cigarette smoking leads to vasoconstriction. Okay, so we know and we understand the connection now between atherosclerotic plaque narrowing or occluding the coronary arteries. What we want to make sure doesn't happen, and the interventions up until this point are largely for the prevention of thrombus formation. Now we have stable versus unstable plaques. Now stable plaques, they will gradually increase in size, but the occlusion is very slow, or it's just going to be a partial occlusion in the vessel lumina. Okay, it will limit the coronary flow, causing ischemia, especially it will be exacerbated during exercise. But the unstable plaques are the ones we are really worried about because they're prone to ulceration and rupture. And now, even if there's no significant impairment of coronary blood flow, which can happen, there may not be any gradual increase in size, but that plaque can break off, ulcerate, rupture in that site, and we wouldn't have a clue until that point. So they are prone to having more difficult outcomes when these occur. The underlying tissues of the vessel wall are then going to be exposed, which will result in platelet adhesion, thrombus formation, and if these thrombi are suddenly cutting off the blood supply, because now the thrombi itself is causing the occlusion, then we are going to have a cutoff of the supply of blood needed for our heart muscle. Now we're in myocardial ischemia, and the vessel that's obstructed can't reverse rapidly, and if it goes over that 20 minutes, then now our ischemia has progressed to infarction. Okay, cardiac or myocardial infarction is what is more commonly known as a heart attack. Okay, so now we're going to get just a little bit more in depth about myocardial ischemia. We know, again, coronary arteries supply blood to the heart muscle. If this doesn't happen efficiently or sufficiently, then we're going to have a decrease in blood flow, and we are not going to meet the demand of the myocardium. Once there's 50% narrowing of these arteries, impairing the flow, this is enough to change the cellular metabolism in this site, especially when the demand increases, like when we're more active or we're exercising. Ischemia occurs within 10 seconds of any coronary occlusion. Okay. This eventually can be detrimental if it progresses to over 20 minutes. Again, that is going to be what leads to myocardial infarction. But let's look and see now what happens at the site of ischemia. Okay. And we want to know what are the common causes that would actually increase the demand for blood that could get us to a point where there might be these 10 seconds of coronary occlusion. So first, think about when your heart, if any situation where your heart may become tachycardic, maybe you have a fever or you're compensating for like a low blood pressure or you're in sepsis. Tachycardia will make it where your heart is demanding more blood. Exercise does the same thing. Hypertension, especially in the presence of hypertrophy, usually at the left ventricular area. Valvular disease as well. And it can result from other causes of decreased blood and oxygen, such as when someone is having a coronary spasm, hypotension, dysrhythmias, decreased oxygen carrying capacity of the blood, which is situations where patients are anemic. They're not going to get enough hemoglobin, which carries the oxygen to the blood. They might become hypoxemic, which means that there's low oxygenation within the blood. Aortic valvular disease may also cause myocardial demand as well. Now, these cells are ischemic within 10 seconds, and after several minutes, that heart cell will lose the ability to overall contract. If your heart can't contract, then what happens to your cardiac output? It's also going to decrease. It can cause conduction abnormalities, which then you're going to see in an EKG or an electrocardiogram, and it might initiate more disruptive and fatal dysrhythmias as well. At this time, you are getting into a situation where your body is now in anaerobic metabolism. When this occurs and you're depriving myocardium of glucose, you will also release lactic acid. And this is why checking for lactic acid is another way to determine your patient's status if you are worried about myocardial ischemia or infarction. Now, these cardiac cells are going to be viable for about 20 minutes total under these very low oxygen or ischemic conditions. And once this blood is restored again, we can move back into aerobic metabolism, and hopefully our contractility will be restored again, and this is when cell repair can begin. So what would you expect to see in a patient with signs of myocardial ischemia? They're going to start to feel chest pain. When it's stable angina, we call this angina pectoris. And this is predictable chest pain that's caused by ischemia. So what are some things that would be predictable to cause this type of chest pain? Again, anything that's causing an increased workload on your heart or need for oxygenation, like exercise or increased activity. Individuals with reversible myocardial ischemia can present in other ways than just stable angina. They can also present with variant angina or Prinzmetal angina. And this is when the pain is very unpredictable. They don't know when it's going to happen, and this is caused by artery vasospasm. A silent ischemia is extremely dangerous because you're going to have no symptoms, and when you don't have any symptoms, you don't go looking for ways to improve your cardiac output or your cardiac contractility, or you don't really understand that you have periods of low perfusion to the heart with silent ischemia. This happens because there's a lack of innervation. So again, individuals with reversible myocardial ischemia can present clinically in several ways. So we're going to get more detail and understand now angina pectoris or stable angina. What is causing this predictable chest pain? The gradual luminal narrowing and the hardening of our artery walls is what causes the pain. The vessel itself can't dilate now in response to increased myocardial demand. When we put ourselves under physical stress, exercise, emotional stress, we need our heart to be able to, our heart vessels, our arteries specifically, to be able to dilate appropriately. And it can't do this because the artery walls now are very narrow and very hard. With rest, the blood flow can be restored though, and there won't be any necrosis of the myocardial cells with stable angina. Angina pectoris is typically experienced as transient substernal chest discomfort. Transient meaning it's going to come and it's going to go. And our patients will complain of sensations that range from like heaviness on the chest, pressure, or moderate to severe pain. And most people that have stable angina will describe the sensation of clenching a fist over that left sternal border. That is what it feels like for them. However, it's very important to note that half the women with stable angina do not have obstructive coronary artery disease, but they have microvascular angina that results from vasoconstriction of the smaller coronary arterioles that are deep within that myocardial tissue. Individuals who have autonomic nervous system dysfunctions, like older adults with diabetes, they will have angina that's mild, atypical, or they can even have silent angina because there's that lack of innervation. With angina pectoris, there is still innervation, C3 to T4 afferent sympathetic innervation. And this is why sometimes we'll have that radiating pain that people will say it's in their jaws and their shoulder, and it's because there's that sympathetic innervation between C3 and T4. The pain can be relieved with stable angina by taking nitrates, like nitroglycerin, sublingual tablets. The stable angina, though, doesn't mean that we're off the hook. It can become unstable, which leads to an impending myocardial infarction. So once someone that says, normally I know what to do when my chest pain happens, I can rest, I can take my nitroglycerin, it goes away again. But once it don't have that anymore, and now that it's unstable, you're really worried that we're taking the turn for the worse. Now, Prinzmetal angina, again, we call this variant angina as well. This is when we have transient ischemia of the myocardium, and it's very unpredictable. And almost exclusively will it happen when the patient is doing nothing. So we can't really attribute it too much. This form of angina will occur more often at night during our REM sleep, or rapid eye movement sleep. And it may be connected to a cyclic pattern of occurrence, but it's very unpredictable. Now, it's caused by it's caused by vasospasm of one or even more of our major coronary arteries, and it doesn't necessarily have to be associated with atherosclerosis. It results from a decreased vagal activity, hyperactivity of the sympathetic nervous system, and decreased nitric oxide activity. Other things that can cause Prinzmetal angina would be if we have altered calcium channel functions in these arterial smooth muscles and endothelial dysfunction. These two things together will promote the release of inflammatory mediators like serotonin, histamine, endothelium, or thromboxane, which would increase your risk of myocardial infarction as well. And we talked about highly sensitive CRP, and it will be, or could be, elevated in our patients with this type of Prinzmetal angina. Now, most often though, Prinzmetal angina can be a benign condition, but can occasionally cause serious dysrhythmias. And if we don't treat before it gets worse, or if treatment is withdrawn, then we are again at risk for myocardial infarction. The calcium channel blockers or long-acting nitrates, or a combination of both, can help treat Prinzmetal angina. However, if these vasospasms persist long enough, then we're in a situation where a serious dysrhythmia may occur, or just straight to infarction. Now, more detail with silent ischemia. Sometimes we call this mental stress-induced ischemia, and it can be, again, asymptomatic, and because of that lack of innervation that we talked about with patients that have like diabetes, for example, they don't know that it's happening. Our patients will say, well, I feel very fatigued, or have a little bit of shortness of breath, or I'm just kind of uneasy, and I'm not sure why. This lack of innervation is due to an abnormality on the left ventricular area. That sympathetic afferent innervation is not working appropriately. There also could be denervation that occurs during a cabbage transplant when we have a coronary artery bypass graft or cardiac transplantation. This can also happen following an ischemic local nerve injury that can be caused by a previous myocardial infarction or heart attack. When you are in a period of chronic stress, this can lead to increased inflammatory cytokines in your body, making your body to be in a hypercoagulable state, which increases your risk for clots. Many times, though the symptoms are asymptomatic, it could be caught and detected by taking a stress radionucleotide imaging study, and this is where they will find actually that there is an issue with the coronary artery. You will also see this type of ischemia associated with increased CRP levels as well. You're going to see it with a decreased activity of nitric oxide, which is a vasodilator, and you might pick up labs that show that you're in a hypercoagulable state. A patient is complaining of having intermittent chest pain after exercise. What's your most likely cause? The answer here is going to be atherosclerotic plaque progression, which progression means that it's gradual, leading first to stable angina, which is that predictable chest pain caused by myocardial ischemia, which again, this is a decrease in perfusion from 10 seconds up to 20 minutes, and it's in response to increased demand without infarction. Now, we alluded to mental stress leading to MI when we talked about silent angina, but let's look at the pathophysiology behind this. It really is working at the central and autonomic nervous systems, and the stress produces this cascade of responses that can lead to a heart attack. Eventually, starting with myocardial ischemia first, and maybe there's dysrhythmia, plaque, but it can lead to potentially fatal dysrhythmias or plaque rupture or thrombosis, all leading to a heart attack or myocardial infarction. Other things to think about are ventricular fibrillations, ventricular tachycardia, and left ventricular issues. This can all lead to the sudden cardiac death or myocardial infarction. And you can see here the specific mechanism. So that was an overview, but let's look at the specific mechanisms now. Mental stress itself can precipitate VFib or ventricular fibrillation, and we don't really understand why, but there are some possible explanations that are worth considering. Our body in times of stress, we go through that sympathetic nervous system or SNS fight or flight response. Once it becomes activated, our stress hormones are going to be released. Those hormones are going to be adrenaline. This increases our heart rate, our blood pressure, and the way our heart contracts. With patients that are susceptible with underlying heart conditions, this additional surge of SNS activity can be so much that it's disrupting their normal electrical conduction system and the normal response that they have in their heart. And this could lead to VFib. We also know that with coronary artery constriction, this can be a result of mental stress as well. When this happens, the supply of oxygen and nutrients to the heart is compromised, and this reduced flow plus knowing that the arteries are narrowed can lead to myocardial ischemia, again leading to arrhythmias like VFib. We also have a pathophysiologic result in response to our platelet activities. And this is the promotion of the activation of platelets and the release of prothrombic factors. This will lead to an increased time of blood clotting, and it can aid in the formation of these small blood clots, which isn't good because these blood clots can disrupt the blood flow within the coronary arteries. It can trigger ischemia and arrhythmias like VFib. And the last thing we'll talk about is this autonomic imbalance that happens when we are mentally stressed. It disrupts the balance between our sympathetic and our parasympathetic branches of the ANS, or autonomic nervous system. When we have excessive sympathetic activity, in addition to reduced parasympathetic activity, this imbalance can change our heart rate control and our electrical stability, which would increase the risk for arrhythmias, all putting you at risk for sudden cardiac death or myocardial infarction. This question wants you to know what type of angina is being experienced with abnormal vasospasm of the coronary arteries. And we know that from our previous slides that this is describing prinzmetal angina. This type of chest pain is attributable to transient ischemia of the myocardium that occurs unpredictably and almost exclusively at rest. Did you know that men and women experience cardiac symptoms quite differently? The classic symptoms that most healthcare providers talk about and most patients understand to be attributable to a cardiac ischemic event or infarction is this crushing sternal chest pain. And they'll also say it radiates down the left arm. Well, with men, this presentation is pretty classical, and you will see this jaw pain, substernal pain, pain radiating to the arm, a little bit of epigastric pain. However, with women, there's various types of symptoms. They may only have nausea, may only feel back pain, may only experience shortness of breath or fatigue. They may not have this substernal chest pain that we're so used to hearing about. Now, the discomfort of cardiac pain may be mistaken for GI type symptoms like GERD or indigestion, but the pain is caused by the buildup of the lactic acid that's being released when our body's in an anaerobic state, or the abnormal stretching of the ischemic myocardium, which can irritate the nerve fibers. Remembering that there's an afferent sympathetic fiber system, so fibers that enter the spinal cord from C3 to T4. And this is why we have such a variety of different locations in which a patient could experience cardiac symptoms, and that they can radiate, being very textbook of anginal pain. However, women will have atypical chest pain, palpitations, just a sense of unease and not feeling well. So don't discredit that it could be a myocardial ischemia or infarction just because it doesn't fit the classical symptoms. Please do your due diligence and get a very thorough health history and advocate for a very thorough workup if it's not being done. When we talk about acute coronary syndromes, this is when there is a sudden coronary obstruction that could be caused by blood clot over ruptured or ulcerated atherosclerotic plaque, or you have ischemia that's occurred. When you are in acute coronary syndrome, this will also include angina and possibly infarction. And the angina that we're talking about is unstable, and it's the result of reversible myocardial ischemia but it is really just that signal or harbinger that there's impending infarction that's going to eventually occur. And MI results when there's prolonged ischemia over 20 minutes, and it causes irreversible damage now to the heart muscle. But MIs itself can be subdivided even further to a non-ST elevation MI, which we call non-STEMI, or an ST elevation MI, which we call a STEMI. And the difference is where how much damage occurs in the heart muscle, and you're going to see this in a couple slides. While sudden cardiac death occurs as a result of any of these acute coronary syndromes if we don't intervene appropriately. When an unstable atherosclerotic plaque is prone to rupture, it is going to be richly deposited with oxidized LDLs, and it has this very thin fibrous cap. It becomes unstable, and then it can extend into the lumen of the vessel and can be silent clinically, meaning we don't really see signs or symptoms until the time of rupture. Also, plaque disruption, like ulceration or rupture, can just occur because of force itself, shear force, inflammation with the release of multiple inflammatory mediators, secretion of macrophage-derived degradative enzymes, and our cells' apoptosis can also cause lesions that can increase this coronary artery syndrome. When these plaques become exposed, they activate the clotting cascade, causing platelet activation, the release of coagulants, and then it can result in more platelet aggregation and adherence. Overall, the thrombus can just continue to form and form very quickly until we have occlusion, which will then further exacerbate the release of the vasoconstrictors that we need, such as thromboxane A2 and endothelin. The thrombus can break up before permanent myocyte damage occurs, and this is great. This is unstable angina. Or it can cause prolonged ischemia, which will then result in MI. Okay, so there are some diagnostic tests that we try and we aim for that can help diagnose these early, and those are intravascular ultrasounds or MIs, angioscopy. We can also provide medications like statins to break up the cholesterol, ACE inhibitors, and beta blockers can stabilize plaques and prevent rupture as well. But the whole idea is, trying to not get to a point where we're in acute coronary syndromes, but if we are, we need to stop and sustain the ischemia before it turns into an infarct. Okay, so we know about unstable angina. We know this happens when there's an atherosclerotic plaque that's ruptured. But what causes this to happen in the first place? Well, there's fissuring or superficial erosion of that plaque, which leads to a transient episode of thrombotic vessel occlusion. This occlusion is going to lead to vasoconstriction at that site where the plaque has damaged the blood vessel. Now we have a thrombus that is very unstable or labile, and it can occlude the vessel. Although, if we can resolve this within 20 minutes and we get the return of perfusion before more significant myocardial necrosis occurs, then we're okay. If it goes beyond the 20 minutes, then we are in trouble for myocardial infarction. Individuals that experience increased dyspnea, diaphoresis, profuse sweating, and anxiety, these are actually manifestations that I worry about, because this is usually what tells me that the angina is worse. With new onset angina, though, they might not even feel it all the time or at its rest, and that's when where we're talking about the differences of the types of angina really pointing to the severity and the frequency of pain. So now looking very closely here at what it looks like inside the vessel when there's plaque disruption leading to myocardial infarction. There's the cap of that lipid-rich plaque tearing off, and it's forming the thrombus. Then here you can actually see in this picture that this is a 6-day-old infarct where the center is yellow and necrotic, and you have that hemorrhagic rim over it. This is what was responsible for the occlusion here. And now you can see the infarct on the posterior wall going through the lumen. Looking at a more algorithmic progression, we have the plaque, this lipid-rich core. Again, the shear forces of inflammation, apoptosis, macrophage degradation, plaque ruptures. Then we have, because in response to the plaque rupturing, we're going to have the inflammation response. We're going to have cytokines, platelet activity, and adherence. We're going to have thrombin and vasoconstrictors coming in. The thrombus forms over the lesion, and vasoconstriction of the vessel is happening. When vasoconstriction happens, there's not a lot of room or space for blood to flow. So we're in acute decrease state of coronary blood flow, leading to unstable angina or, with over 20 minutes, myocardial infarction. Okay. By definition, myocardial infarction is insufficient coronary blood flow or oxygen that's insufficient to meet the cardiac or metabolic demands of the heart. And you see all the different reasons why here. The decreases blood flow, starting with atherosclerosis, which we talked about, thrombus. You understand now how that's associated to atherosclerosis, leading to situations where like anemia or decreased oxygen carrying capacity. Well, there's also situations with increased demand, like tachycardia, exercise, and hypertension that we talked about. Well, this right here will help you to understand the different zones of ischemia and where these things are happening. Remember, I talked about a non-STEMI versus a STEMI, which are two different types of myocardial infarctions. With the non-STEMI, on an EKG, you're not going to see that ST elevation because it's only affecting partial lumen. But with the STEMI, it's going all through the layers of the lumen itself, or the vessel itself, which you will see ST elevation on EKG. Okay, so it's just talking about, how much of this endocardium space is being affected. It is worth noting too that the reason why you want to know if there's transmural infarction, or that it goes through the different areas of the endo to the epicardium, is because our patients that have a STEMI are at higher risk for serious complications, and they require more immediate interventions. Okay, so we've talked extensively about injury leading to death, and this happens in that 20-minute or more time frame, where now we're in a situation of hypoxic injury causing cellular death and tissue necrosis. Well, within the infarct, that infarcted area of the myocardium is now going to be surrounded by a zone of hypoxic injury, and this is going to progress to necrosis, remodeling, or returning to normal. However, we know that when there's oxygen deprivation, it can be accompanied by electrolyte disturbances. We lose potassium, calcium, magnesium from our cells. And myocardial cells that are deprived of oxygen and nutrients will then lose contractility. Our heart will not pump appropriately. Then the ischemic cells release catecholamines like epinephrine and norepinephrine. This will also predispose our patient to imbalances of our sympathetic and parasympathetic function, causing dysrhythmias and heart failure. The catecholamines will mediate the release of the glycogen and glucose, and the surrounded fat, the stored fat from the body cells as well. And the plasma concentration of free fatty acids and glycerol will now start to rise an hour after the MI. Excessive levels of free fatty acids can have very harmful effects on the cell membrane, where norepinephrine elevating our blood glucose even further through the stimulation of liver and skeletal cell muscles. We're also going to have a suppression of our pancreatic B cell activities, which will reduce insulin secretion, so you're going to see elevation in blood glucose even further. Also, we see that angiotensin II is going to be released during myocardial ischemia, and it contributes to the pathogenesis of MI in several ways. First, it results in the sympathetic effects of the peripheral vascular constriction and fluid retention. We also are going to see angiotensin II being released locally, where it's a growth factor for vascular smooth muscle cells, myocytes, and cardiac fibroblasts, which will then promote catecholamines to be released and coronary artery spasm. Ischemic injury can be exacerbated by what we call a reperfusion injury once blood flow is restored. And this process is an important one to understand because it involves the release of toxic oxygen radicals, calcium flux, and pH changes that will sustain myocardial permeability transition pores. This contributes to resultant cellular death. Additionally, infiltration of inflammatory cells will contribute to the tissue injury at that site. Degradation of damaged cells, proliferation of fibroblasts, and the synthesis of scar tissue. Within 24 hours, this is all happening in repair response to the cellular injury. Now, the leukocytes will infiltrate this necrotic area with proteolytic enzymes from scavenger neutrophils, degrading the necrotic tissue. They're going to lay a collagen matrix deposited, and initially, this is going to be very weak and mushy. And at this point, you're very vulnerable to having a re-injury. It does take up to 14 days after the infarct to where now you really are feeling like you can start to feel better, okay? That you feel like you want to do things again. And then the stress of that can form more scar tissue. After 6 weeks of the necrotic area being completely replaced by scar tissue, your patient's going to feel a little bit better. Their heart is going to feel stronger. Contraction is going to go over better, and they will feel just a little bit healthier at this time. But you see that it takes several weeks for all of this to happen. At this time, we hope to have a increased cardiac contractility. We hope to have more stroke volume or increased stroke volume and more cardiac output. If not, if it prolongs and your heart isn't able to repair, then we are left with decreased cardiac contractility, altered ventricular compliance, decreased stroke volume, less ejection fraction, and ultimately it can lead to cardiac heart failure. Which statement regarding cellular injury of the myocardium is correct? Well, hopefully you know this answer because I keep repeating it so that you will know the answer. It's C. After about 20 minutes of myocardial ischemia, this is when we lead to irreversible hypoxic injury that causes cellular death and necrosis of the tissue. 20 minutes is the magic number. So you can see here everything that we've talked about on one slide in terms of the difference between ischemia and infarction. So at this point, you should be able to talk through this slide yourself and to share it with someone else pretty confidently to help confirm your understanding of the difference. But let's go through quickly. Now, myocardial cells are going to become ischemic within 10 seconds of coronary artery occlusion. And after several minutes, you are going to lose the ability for your heart to contract, your cardiac output will decrease, and ischemia will cause conduction abnormalities, which you're going to see in EKG changes. We have the anaerobic processes that take over. Remember, this is when the lactic acid starts to accumulate, and you can pick that up in your blood test. And you know at this point cardiac cells are going to be viable for about 20 minutes. But once we get to this 20 minutes, then we're at greater risk for dysrhythmias. If it is beyond the 20 minutes, now we might have a situation where our heart will not contract at all. The electric impulses will not respond. We have a failure to contract, and not only will we have dysrhythmias, no contraction will lead to impaired cardiac pumping. Okay, so you see how both ischemia under 20 minutes and over 20 minutes leads to impaired cardiac pumping. So both could really lead to heart failure, and the dysrhythmias can lead to sudden death. So whenever there's an imbalance between what our heart needs, so that's coronary supply, and what our body and our heart tissue demands, then we have this oxygen deficit. Infarction is irreversible, where ischemia is reversible in most cases. So here it is again, this slide with this picture, but now I wanted to bring your attention to the biomarkers. Troponin 1 and INT, these are very sensitive to heart change, and they are more specific. Troponin is going to be more specific than creatinine phosphokinase, MB, or more commonly referred to as CPK-MB. Though this can tell you that there's heart issues, this is going to tell you that there have been these these vessel wall changes. Also, you can check for lactate dehydrogenase, which is LDH. Remember, I was telling you that during your anaerobic state, your body releases lactic acid. Now, this isn't a strong indicator because there's other reasons why your body can go into an anaerobic state, but it does help with the overall picture. Okay, so test your knowledge again between the difference between STEMI and non-STEMI at this time. Which enzymes are released by damaged myocardial muscle tissue? Select all that apply. If you've already forgotten, go back a slide, but you should pick CKMB, LDH, which is the lactic acid test, and troponin. And ask yourself, which one is the most specific for MI? If you said troponin, you are correct. This is the most specific for MI, although all three can help tell the picture. Myocardial infarction is a situation where you are in acute coronary syndromes, and either it can be an ST elevated infarction or a non-ST elevated infarction. With non-ST elevation, you may have only seen unstable angina, With ST elevation, there is myocardial infarction that can change the EKG. You can see that ST elevation on EKG segment. And within ST elevation, there's another subcategory called Q wave versus non-Q wave myocardial infarction. When you see the presence of a Q wave on an EKG during an acute myocardial infarction, this is already telling you that there's necrosis of the myocardium. ST resolution following fibrinolytic therapy indicates that there has been successful tissue reperfusion. And so it's also important to check an EKG after intervention as well. You can see the ST elevation here, this ST segment, and this is what a normal EKG looks like from your S to your T wave. With a non-STEMI, you'll see an ST depression. With the STEMI, you see an ST elevation. You can also see T inversion or ST inversion when there's a non-STEMI as well. But this is what you're looking for normally. If you can at least pick out that normal ECG, you can further understand the differences with the abnormalities. But first practice finding the normals. When you have prolonged QT interval, this can also lead to dysrhythmias. A prolonged PR interval usually tells you that there might be first degree AV block, but you will have a in-depth EKG class to go over these things. So at this time, it's not important that you know all of the EKG abnormalities. For pathophysiology, here you need to know the difference between ST and non-ST elevation MI.